Good afternoon, everyone. A little bit nervous, so just bear with me at the moment. We're really delighted to have won this. We've done a lot of hard work with our families, and today the pinnacle of that, and to be able to take that back to Northumberland and share with our relatively small team is fantastic for us. So, there's two initiatives that we did within the team that I want to talk about today, because one heavily involved co-designing with our staff and the other with our Jewish population, and I'll talk about those in the second half of this presentation. So who are we? We are funded by NHS England. We are a commissioned service, so every 5 years we have to prove our worth. We have two clinical leads, myself and Stephanie Gibbs. We're specialist community public health nurses, and unfortunately Stephanie can't be here today, so I'm gutted for her. We've got a band 7, 2 band 6s, we have band 5 nurses, but they're only equivalent to 14 whole-time equivalents, and we cover an area of 2,500 to 3,000 square miles, so our nurses work really hard. Our backbone is our admin team. We could not survive without them, and we're really proud of how we all pull together, and we've all got a real drive to tackle health inequalities with our young people. We cover Northumberland, North Tyneside and Newcastle, and this year when our contract was awarded again, we took on Gateshead. We deliver into 497 schools with a cohort of around 150,000 children and young people, so by no mean feat. Every child has to have an offer of vaccination, 100%, else we have to answer to the commissioners and why we haven't done that. Just a very quick brief rundown of what we do. It's an all-year-round programme. So we're knee-deep in flu at the moment. Our nurses are out from the primary schools right the way through. Then we do our teenage booster programme, diphtheria, tetanus, polio and meningitis ACWY. My favourite, and the one that I'm most proud of, we do our HPV programmes from April to June, and as you'll have heard, measles is on the rise, so we are now targeting all children who haven't been vaccinated or only had one, and we're doing some catch-up campaigns for that. So what is the difficulties for our team? And our difficulties are health inequalities, and the reasons why that is. Every one of those 4 areas that we talk about today have health inequalities. Northumberland is beautifully rural, but there are some real pockets of deprivation. And then you have inner city Newcastle with language barriers and asylum-seeking populations and our cultural groups. We have a lot of digital poverty, so there's lots of areas for our nurses to take on board and think about how we're going to deliver this and how we're going to reach our families. One of the things that we looked at as clinical leads was our outreach clinic programme. If a child's absent in school, or if they miss the deadline for getting their consent in, they're given an invite to clinic. Now, we inherited a service that came from the devolution of the school nursing service. So our initial team worked term time only, and the majority of them worked school hours. The downside of that is our clinics were designed around the needs of our staff and not the needs of our families. And as you can see here, I apologise for the busyness of the slides because IT is not my strong point. But these are the clinics that we had. We had 33 clinics running. The darker blue is the amount of slots that we had, those 5-minute slots to get kids in and get them vaccinated. And the uptake and the was not broughts are the very poor numbers across the bottom. Our clinics would run and really finish by 4:30 at the absolute latest. 31 clinics, 33% was not bought rate, but only 26% of those slots were being booked in the first place. Then you're losing 33% of those. So we thought we need to find out what we need to do differently, and the only way we could do that was to look at those families who had a valid consent. These weren't families we needed to do any work with. They wanted the children vaccinated, so what can we do to help and support that? So the participation came from contacting a sample and said, can we just talk it through? You haven't come. We've offered you 3 clinic appointments. talk to us and tell us what would work for you. We had to develop that, and that was really difficult. Our families told us, I work shifts. I don't want to come to a clinic on a Saturday. My son plays football. Like, I can't take my child out of school very easy. The development of that was looking at how we would put on clinics to a term time only team that could incorporate late night working and weekend working. So we were taking that shift from a very traditional school nursing format into an all year round late night service. I'm not going to pretend it was easy. We had to go through an organisational change process, and for our team that was really difficult. People were in our team because they loved the freedom of having 6 weeks off with their children in the summer, you know, and what that meant for them long term. What are your goals and your objectives here, Caroline? And am I going to lose this great contract I've got? We give them ownership with that, and they could say that what we wanted to do was the right thing to do, but they just couldn't initially see how that was going to fit in with their work-life balance. So one of the things we did with that ownership and power with our team was to say to them, what would work for you? These are how many clinics we want to do, and let's trial it. So we did that, and we changed our working day from 8 in the morning till 8 at night, and we put on clinics throughout flu, with the caveat that we would reevaluate all of that at the end of that first campaign, and if this is successful, we'll run with it. If it's not, we go back to the drawing board. It certainly didn't want to be a top-down approach from my point of view. I want staff to be happy and proud of what they're doing. So we decided, and that's what we agreed. And that's just a little bit there. We looked at comms. We looked at how we would use QR codes to engage staff and people. And we looked about where we would put those clinics. Those clinics were originally, if you look at public health research, those clinics will tell you you need to be in the heart of those communities, those deprived communities. And we turned that on its head. We put those clinics in the front and centre of those local communities. We have a phenomenal clinic in the Gateshead Metro Centre. We vaccinated 400 children in one session in Gateshead Metro Centre. So there were really high traffic areas. Families fed back, this is great, we can do our Christmas shopping when we're finished and we can go for tea. And so that has snowballed, and that has continued to work really well for us. The result of that was 22 clinics as opposed to 31, and our was not brought rate was reduced to 9%. So it was the right thing to do, and we're really proud of that. The staff now self-roster. They know the dates of the clinics, they work it, and they self-roster when they can do that and it fits in with their family. We took on a new area this year, and that was the Gateshead area. It covers the ICB areas, and that's how we got that. That increased our cohort. HPV is a real passion project of mine. I was in Westminster with our other clinical lead in January because the government wants to eradicate cervical cancer by 2035. Northumberland is one of the very few areas our team delivers that hits that 90% uptake mark, which will give us a good indication that cervical cancer will be on target to be fully eradicated. But we knew from all of our work with public health that the Jewish community did not uptake HPV. We worked with the Jewish Community Council, and the first thing we said was we have one opportunity to make a first impression. Tell us about your culture. Tell us what's important to you. Tell us about your Sabbath. Tell us what you do. And that built up a fantastic working relationship. One of the things that we did with that is we did co-design with the Jewish Community Council and the local GP. The local GP is highly, highly respected in this area. And if she says this is the right thing to do, then most of the community will buy into that. We started backwards. We said to them, this is what we want to achieve. We want to be a team that actually can prove that we can go against the norm. It's not a given that these people will not have this vaccine to prevent these cancers. That's our outcomes. That's what we want. How do we work backwards from that to get what we need? So we designed this HPV poster and information pack for the families. The poster has got a QR code on. It mentions nothing about sexual contact because that is such a taboo subject within that culture. And that will just tell you what our uptake is from that piece of work. Our previous provider had no uptake for HPV, and we've now, in our first year, we've managed to vaccinate and protect 52% of that cohort. So we know those children will not have the cancer diagnosis. Thank you.